Okay.
Hello.
Hello, can I share my screen?
Yeah, let me make you a co-host.
That would be fantastic.
Do you have some capabilities now?
I do.
Awesome.
You can see my stuff.
Yes. Full screen looks great.
Okay. Now we just wait for people.
Yeah, so I think a lot of the sessions were just finishing up. So we've seen that probably giving people in like 5 to 7 minutes
Wait
extra.
till 12:10.
Yeah.
Okay.
And this session is recording. That's okay, right?
Yep.
Okay, cool.
It's all right with me.
Are you going to want the video at all?
Yeah, I'll turn the video back on.
No, sorry. The one that was previously recorded. I do have like the YouTube link for that Lisa.
Oh, no, don't worry about that.
Okay, I will X out of that.
Yeah. Hold on. All right, y'all that are signing on, we're going to start at about 10 after. Make sure everyone's got time to get on that wants to. All right, we're going to give just a few more minutes, transition time for everyone, and then I'll get started. All right, I'll go ahead and get started. Anyone else who logs in can catch up. My name is Josh Weil. I am the Regional Overdose Prevention Specialist for Region 7, which is Shelby County, Tennessee. There are 22 of us across the state, and every county in Tennessee is covered by our services. We are essentially Naloxone trainers. We also train on harm reduction, stigma, science of addiction, and we train individuals and family members of at-risk people. We also train agencies, first responders. We particularly focus on law enforcement and agencies that work with high-risk individuals. If you know of an agency that needs Narcan, we can actually provide Narcan for them to have on site that they can use on site or give to high risk individuals that are leaving a program or leaving AMA or something like that. We have distributed quite a bit of Narcan over the last 3 years, and I will talk about that towards the end of the presentation. So I work through the Memphis Area Prevention Coalition, and most of us across Tennessee work with local coalitions, and we are a harm reduction coalition. And so harm reduction, we try to keep these catastrophic events from happening while a person is still using. It is very difficult to come in contact with a person when they're actually ready to get some help, and it's very rare actually. So in the meantime, what do? And we do things like the Narcan program, which is to keep people alive. Obviously, that's the kind of harm we're trying to reduce. We don't need a study to show us that if you're dead, you can't recover, right? So we also run a syringe exchange program, and we have access to medication assisted treatment through other programs that work with us. And, with the syringe exchange programs, we're preventing HIV, hepatitis C, endocarditis, things that often come along with injection drug users. And we, right now the HIV rate in Shelby County is 6 times its normal. We're one of the highest in the nation. Now, we haven't had syringe exchange programs here, but for a very short time. That other big urban areas in Tennessee have them and have had them for several years. So that may be part of the reason, but they have done studies in New York and DC that show the instance of new cases of HIV was reduced 70% amongst this population with needle exchanges in place. So hopefully we'll be able to look at that data as some time goes by and see a decrease in HIV and hepatitis C cases. So we also provide safe disposal. We do testing on site. We provide education about safe injection practices and referral to treatment. And that's a big one because, people, there's a lot of stigma around syringe service programs about helping people use drugs. And even on a state level, like you cannot use federal money to buy needles. And the reason behind that is because it helps people to use drugs. But the fact is that people that are part of a syringe service program are about 5 times more likely to get help because they know where to go when they are ready to get help. When they're in that short little window of, hey, I've had enough, I'm ready to get help, they know exactly where to go and they know that we can get them in. And also, that's a point of contact for us to distribute Narcan directly into the hands of the high risk population. We have clients that have had Narcan used on them 12 times in 1 week, but they inevitably end up getting treatment and getting better. And so stigma is a big issue with substance use disorder. We want to use person first language. So, if Bob has cancer, we don't call him a cancer, right? But if Bob has substance use disorder, we call him an addict, a junkie. We want to look at the person first. It is a person with a disease. And beware of unintentional bias. And, I believe a lot of the stigma around addiction is a misunderstanding of what addiction is. And people tend to look at the behavior and see, these ridiculous things that we do. And I say we because I'm in recovery and I've done them. And it's looked at as that person's fault. It's one of the only diseases we say it's the fault of the person who has it. And we will categorize it as a moral issue or an issue of weak will, or it's a bad person, and not have any understanding of what's going on behind that behavior, of why that behavior is taking place. And so I do talk a lot about, the science of what's going on, why addiction is a disease. We hear about the disease concept of addiction. It is not a concept. It is not a model. Addiction is a disease. There's about 75 years of research that shows that and proves that. It shares characteristics with many other diseases. There are predisposing conditions. There are changes to the brain. So back in the 50s, this was 1959, 2 doctors did an experiment with mice and rats, and they inbred these mice and rats for 20 generations. And what that does is creates a group of mice and rats that are genetically identical. So the males of that group turn out to be about 98% genetically identical. They took these groups and they separated them by strain. So each group had the same genetic code, and they made drugs and alcohol available to the groups. And guess what happened? So some of the groups would habitually use the drugs and alcohol. Some of the groups would completely ignore it and leave it alone. Other groups would moderate. So they said, well, there's something going on here, something genetic. There's a predisposing condition. They called it genetic susceptibility. They didn't quite know what it was at the time. They just knew it was there. But now we do know what it is. So, we've done the Human Genome Project. There's been about 90 genes associated with addiction isolated. So there's not one gene that says I'm an alcoholic or I'm likely to be an opioid addict. It is a combination of about 90 genes. And what these genes determine are things like uh, metabolism, how fast your body gets rid of a substance, how many enzymes your body produces to get rid of a substance, how tightly a substance attaches to your receptor, how sensitive the receptor is to that substance. So all these things in combination, what they manifest as and what that looks like is people don't experience drugs the same way. So it is a completely different feeling, a different experience for some than others. Some of you have probably gotten a pain pill from a doctor or dentist. About 9 out of 10 people will take that pain pill and it will not be a pleasant experience, right? It make you groggy and itchy and it makes your stomach hurt and you don't like it and you take it for pain and put the rest of it in your medicine cabinet and never think about it again. Well, if you are genetically susceptible to opioids, to opioid addiction, you take that same pill and it is a completely different experience. You get euphoria, you get a feeling of warmth, a feeling of well-being. For some people, particularly people with trauma, people with a high ACEs score, painfully shy, nervous all the time, full of anxiety, generally uncomfortable, sometimes they take that pill and it's a revelation, right? It is the first time they've ever felt comfortable in their skin for as long as they can remember. Where has this been? Why haven't I felt like this my whole life? You know, so it's a different payoff for people that are genetically susceptible to whatever the substance is. Alcohol is the same way. People don't experience alcohol the same way if they're an alcoholic. It's a different feeling. It creates a craving. The more they drink, the more they want. A non-alcoholic, the more they drink, the less they want. That's the person that puts down a half a glass, says, I've had enough, and walks away. An alcoholic will be having a craving that they can't control. So it is a different experience. Now, does that make a person have substance use disorder or alcoholism because they are genetically susceptible? And of course, the answer is no. The problem comes with repeated use. So that person that's genetically susceptible is much more likely to continue to use that substance. Now, this is where the problem arises, and the problem arises because drugs and alcohol use a person's survival system. This is what's going on, and this is why the brain is hijacked. Most people like food and sex and things like that. Now, there's a reason why we like those things. We are wired to like those things because they help us to survive and procreate. So there's a system in our brain that learns to continue behaviors that are good for our survival. And what happens with drugs and alcohol, in essence, is our brain is tricked into thinking something harmful is good for us. Not only good for us, but better for us than anything we've ever done, because it's about 5 to 10 times more potent a reaction than it is from food or sex. So when the pleasure center goes off with food or sex or something like that, it acts indirectly. When drugs or alcohol are involved, it acts directly on that system, and you get a 5 to 10 times higher response. So the rest of the system in turn responds at a higher rate. And the way it works is you get something that's pleasurable, and your pleasure center, which is called your nucleus accumbens, will send a signal to that little area on top of the brainstem called the VTA, which is the ventral tegmental area. And its only job is to release dopamine. It floods the nucleus accumbens with dopamine. Dopamine does not cause pleasure. They used to think that, but they have since determined that that is not true. It didn't make sense because dopamine is also released in stress, and people with Parkinson's have low dopamine, but they still experience pleasure, right? And there was a number of other experiments, but what they figured out is that dopamine gives a person motivation to act. So it creates a want. And it is not the kind of want where you plan something out like, I'm going to go to school and I'm going to do this. It's a craving, is what it is. So if you can imagine, so imagine a time that you decided you were going to go on a diet and you're not going to touch any sugar and I'm going to eat nothing but chicken and brown rice today and exercise. And then by noon, you have a piece of chocolate cake in your face, right? Now, why did you make a decision and then against your own will do something you didn't want to do? Well, the reason is because sugar has a high dopamine response, right? It's instant energy, stored energy, great for survival. So you're getting a lot of dopamine pumped out and you're getting a craving. And that craving made you give into it, right? Well, imagine that craving about 5 to 10 times more intense. And that's what we're looking at with drugs and alcohol. Now, we have, as human beings, a large prefrontal cortex. And this is the system we use to inhibit our drives and our cravings. And sometimes we are successful, right? We decide we're going to go on a diet, we're able to do it. It's because we have a big prefrontal cortex and we're able to overcome that system. Well, with continued drug and alcohol use, your prefrontal cortex actually shrinks, it loses mass, the neurons become misshapen. And if you've ever seen one of those pictures of the brain where it's all lit up on one side and then the other side says 8 weeks of crystal meth use or whatever substance, and then you got little bitty lights, that's your brain activity in your prefrontal cortex. And that goes down as well. And the longer drugs are used, the dopamine system becomes more sensitive, causes higher cravings, and the prefrontal cortex becomes more damaged. So our system to inhibit those cravings is now damaged. So what that looks like is a person that no matter what they decide or no matter what their rational thought tells them, the most important thing that they feel like they have to do is this drug or this whatever the substance is that they're using. Now, this is true in every addiction. This is the same cycle in gambling addiction, sex addiction. It is a problem with this dopamine release and the inability to overcome that. And that's why they say it's a hijacked brain. Your survival system literally is running the show, and that person is left without a choice but to act upon that craving. And they have the ability to overcome it is no longer a part of the picture. So when we see, people selling their bodies, people letting their children go, people losing jobs, getting divorced, seemingly deciding to choose drugs over all these other things, it's not because they want to, it is because they are compelled to. And that's what we're looking at when we're looking at addiction. So with opioids, we have a whole nother set of problems, right? We have tolerance, physical dependence, and withdrawal that go along with doing opioids. The other drugs also do. Alcohol has the same thing. It's a little bit different, but it's also very similar. When you're putting too much of something in your body likes homeostasis, right? It likes to be balanced. So it uses compensatory mechanisms to try to balance your body out. You have all these opioids in your system. So your body will start destroying its own opioid receptors and it will start producing chemicals that oppose the effect of the opioids. So over time, you have less and less receptors to receive the opioids. You have more of these chemicals that are speeding everything up, trying to match the damage the opioids are doing. And what that looks like is over a period of time, I have to do a larger amount of opioids in order to get the same effect. Now, what that also looks like is when opioids are out of the system, you don't have enough opioid receptors to function normally. So we're going to be hypersensitive to pain. And then you have all these excess chemicals in your system speeding everything up. And what that looks like is throwing up, diarrhea, high blood pressure, muscle cramps. So this is withdrawal symptoms. And that person cannot function without the opioids in their system because they're going to have all these excess chemicals for a number of weeks. And your body will actually keep producing them, expecting you to continue the opioids. So it will preemptively create these chemicals. So it takes a while for that to calm down and that person to not be sick. And that is where the physical dependence and withdrawal come in. So the opioid epidemic right now, and these numbers actually may be a little bit low. This is from 2019. With the pandemic, we saw a big increase in fatal overdoses and in use. But this is what this is basically saying is that someone in the United States is dying every 11 minutes from an opioid overdose. Someone in Tennessee dies about every 5 to 6 hours. So this is the number one cause of accidental death in the United States. It is the number one cause of the death of young people in the United States right now. So that surpassed car wrecks and accidental gunshot wounds, which are historically the number one cause. So some examples of opioids: hydrocodone, morphine, Vicodin, Percocet, oxycodone. These are all medications you would get from a doctor or dentist for moderate, mild pain. Oxycontin is the culprit here in the opioid crisis. This is what the drug companies, they lied. They're getting sued for billions right now. They said this less than 1% of people would become addicted to Oxycontin. And it's not true. It's 10 to 20%, just like every other opioid. And that's what happened. And people started to die because they were overusing their Oxycontin. Doctors were giving it out like candy for, injuries and pain much less severe than warranted time release oxycodone, which is what it is. And a lot of doctors, set up what they call pill mills, but they were pain clinics, and they would write prescriptions from 8 a.m. to 11 p.m., just making money hand over fist. And why not? It's not addictive. But people started to die. They figured out it was addictive. So they stopped, handing it out like candy. And what we ended up having was a whole bunch of people addicted to Oxycontin that could no longer get their Oxycontin. So they went out on the street. They started to buy it there. Very expensive. 180 milligram Oxycontin on the street is $80. They were paying about $6 a pill. So somebody comes along with a little bag of powder and says, hey, this is a lot cheaper, and it does the same thing. So we had a whole bunch of people start using heroin. Then we started to see more people die. And where we're at now is with the next one, fentanyl. Fentanyl is about 50 times more potent than heroin. And this fentanyl is not the pharmaceutical fentanyl that they use to sedate people for procedures. This is being made in laboratories in China and Mexico and coming up through the border and through the mail. And this is driving the huge increase that we see in fatal overdoses. There still are prescription overdoses. There still are heroin overdoses, but the reason why the numbers of fatalities are so high, I'll put it this way: about 98% of the fatal overdoses in Shelby County, we find fentanyl in the system. So this is what's driving the increase, and this is what's creating the need to have, Narcan and people that know how to use it out in the communities. And then we have drugs like methadone and Suboxone, which are maintenance drugs or MAT, medication assisted treatment, that are used as a harm reduction method. So just to give you an example, if you look at this chart, look at the left, that's about a half a gram of heroin. And if you look all the way to the right, that's how much fentanyl equals that much heroin. So as you can imagine, it's good for the drug dealers, right? They can use a lot more cut, make a lot more money, but one bag that's mixed wrong and that person's gone, right? Or if someone takes it and they don't know they're taking it. And we have a big problem there too, because we're having pills manufactured that look like Xanax and Roxicets and Percocets and relatively, mild opioids and benzos. Like Xanax is not even an opioid, but it's pressed fentanyl. And they're getting to where you can't tell the difference between a real one and a fake one. And the fake ones are killing people because they're pressed fentanyl. So the opioid crisis in Tennessee, this number has come down over the years. We're doing better. We're still not great. But if you look at this in 18, 6,052,000 prescriptions, pain prescriptions written in Tennessee. We only have 6,150,000 people in Tennessee. So this is enough for almost a prescription for every single human being in Tennessee. Now, if you think about genetic susceptibility, and about 10 to 20% of people have the propensity to become addicted to this substance, then with a number like that, we're going to have a big problem. And kind of going along the lines of the way the opioid crisis has matured, if you look down there at the bottom, From 14 to 18, heroin overdose increased by about 150%, and fentanyl related overdoses increased by almost 1,000%. So that's kind of what we're looking at now, is these illicit street drugs are driving this. So this is Shelby County information, and this kind of just shows the increase over the years. I think last year, or 2019, we had 341 overdose deaths. 2020, we had 420, and we've already got 155 this year as of about 3 days ago. So what is naloxone or Narcan? Same thing. One of them's a brand name, so I might say both, but naloxone and Narcan are the same thing. Well, the way opioids work is they bind to your endorphin receptors in your body. So your body makes its own morphine. Endorphin means endogenous morphine. So it does this to prevent you from being in pain when you're exercising and things like that. If you didn't have endorphins, exercising would be too painful. You wouldn't be able to do it. And y'all probably have heard of runner's high, right? Where you do so much exercise that you actually feel the endorphins. You can get an effect from it because your body will create enough for you to actually feel it. When you take an opioid from an external source, you will get way more than your body would ever give you. Now, opioids and endorphins use the same receptors. They both do the same thing. They will shut that nerve down to where it won't fire off, and they keep your neurons less excited. They create a sedative effect, so they slow everything down. But it'll block the action potential of the nerve, so you won't get a pain signal. Now, the reason why your body regulates the system so tightly is because there are opioid receptors in the midbrain, and the midbrain monitors your blood to see how much CO2 is in it to tell you how fast to breathe, to keep your oxygen level right. And when too many opioids get on that system, they block that signal. And rather than maintain where it is, it goes down, down, down until that person stops breathing. And that's what we're looking at when we see an overdose. It's respiratory failure because the signal to the midbrain is blocked and it can't read how much CO2 is in the blood, so you stop breathing. Now, what naloxone does, so when an opioid activates that receptor, it doesn't target it. It's random. It'll be floating by it. It attaches it, activates it, comes off. The next one attaches, activates it, comes off. Naloxone will come in, attach, not activate it, and not come off. So it's blocking the receptor. And what it's essentially doing is just not giving the opioids a place to land. So they're out floating in the bloodstream, and the naloxone is blocking those receptors. And as soon as that signal comes back to the midbrain and it sees that high CO2 level, that person back to life. They'll start breathing again, and the effect is almost immediate. It takes a few minutes for the nasal kind to get into the system, but as soon as the brain gets that signal back, the person starts breathing again. Now, it will only last 30 to 90 minutes. That can be a problem because if that person doesn't go with the EMTs, especially if they're in withdrawal, if they're a regular user, it's going to put them into withdrawal right away. They might go out and try to do more drugs. And when the naloxone in 30 to 90 minutes comes off of those receptors, that person can actually go back into an overdose. Now, naloxone does not have the potential for the abuse, or it does not increase risk-taking behavior. People have even reported things like Narcan parties. Believe me, someone with substance use disorder that's doing opioids is going to do as much as they can. And the last thing they want is Narcan because it's going to make them very, very sick when they do it. They will go into withdrawals immediately. And it does not cause any kind of feeling. If someone is not on opioids and you give them Narcan, it's not going to do anything. It'll attach to the receptors, come off in 30 to 90 minutes, and the person won't even know. Now, having said that, you do not need to know that that person has done opioids. And in a lot of circumstances, if someone's unconscious, you're not going to be able to ask them what they took. And when I worked at the ER, every human being who came in there unconscious got Narcan, regardless of what part of town they came from, what they were wearing. Everybody got it. So if you have any reason to think someone might be overdosing, you give them the Narcan. It's better to use it and not need it. It won't harm them in any way. It will only work for opioid overdoses. So if someone drank too much and took a bunch of Xanax and they're passed out, this is not going to help them, but it's not going to hurt them either. And it's available as an injector and a nasal spray. So this is just a picture of kind of what it looks like, what we were talking about. The opioids are the purple circle. They're on the receptors. The light blue is the Narcan. It comes in, blocks those receptors, and the opioids can't get on there. So the risk factors for an overdose: mixing with other drugs, especially alcohol and benzos like Xanax. Both alcohol and benzos reduce neural activity. So does opioids. It is that much quicker to that person not breathing if they're mixing other drugs. Most of the toxicology for overdoses where I'm at in Shelby County show polysubstance use. There usually is more than one substance, up to 12 substances in the system of a person who is overdosed. But the culprit is usually fentanyl toxicity. And the biggest one we see, and the one that's most pertinent to people that work, with people with substance use disorder, is when a person stops taking it and starts taking it again. Because just like the body downregulates those receptors when there's too many opioids, when a person stops taking opioids, those receptors will come back. So someone that's been in jail for as little as a week, that's been using a whole bag of heroin at a time, up until they went to jail, when they get out and they're going to be sick, probably, they're going to want to go use, and they are probably going to use the same amount they were using when they went into jail. Problem is their body now has way more receptors. So to their body, it's like they're using, 3 to 10 times as much, depending on how many receptors they have now. And this is what we usually see when we see an overdose. Someone that has left treatment, somebody that relapsed for the first time after they got in recovery, and they've done too much and it overwhelmed their system because their receptors are back and their tolerance is back down to a normal level. And then using while alone, of course, because there's no one to call 911 and there's no one to use Narcan on you. You can't use it on yourself, right? And we tend to see this in the older population. Just for an example, where I live, the highest rate of ER visits is ages 21 through 29 for overdose. But the highest rate of fatal overdoses is like age 45 to 55. So people that use alone tend to see more fatal overdoses. So recognizing an overdose, there is a difference between being over-medicated and overdosing. I don't know if y'all have ever seen anyone on a lot of opiates. They call it nodding off, where they're kind of falling asleep and waking back up and very confused, garbled speech maybe. But if you can shake a person and they respond, or yell at them and they respond, they are not overdosing. Now, of course, I don't recommend waiting until the person's not breathing to give Narcan. But technically, if that person is responsive, they are not in an overdose. You can even do a sternal rub, where you take your two knuckles and you rub them across the sternum hard enough to hurt them, right? That's the medical measure of whether someone's conscious or not. If they do not respond to that, then they may be having an overdose. So signs of an overdose include loss of consciousness. They're unresponsive to stimulus, very slow breathing or no breathing, choking or snoring or gurgling sounds. And this can be tricky. We had someone here at a halfway house. They actually had Narcan on the premises and they knew this girl was impaired. They sent someone to check on her. They heard the snoring sounds and said, "Oh, she's snoring. She's okay." She died. She did not wake up. Those sounds are your body gasping for air. So it's kind of like the end of life, someone in hospice, when they start to make those noises, the death rattle is what they call it. That's what's going on. So if we ever know someone is messed up and we hear those noises, choking, gurgling, or snoring sounds, give them Narcan. Always. Doesn't matter, don't leave it to maybe, just give it to them. They can be vomiting. They'll be very limp, face pale or clammy, fingernails, lips turn blue or purplish. Somebody that is not breathing, does not look right, their color is off. If someone has really dark skin, you can look at their inside of their lip or their fingernail beds, and it will be dark blue, purple. Pulse will be slow or not there at all. It can happen slowly over the course of hours. It does not always happen to where someone does it and they fall out. So things we do not do during an overdose. People love to put people in cold water when they're overdosing. They think, oh, let's put ice on them and that'll wake them up. Well, if someone is unconscious and you put water on them, if they get any in their mouth, they can drown on very little. It's most likely going to go in the wrong hole. We don't inject the person with any substance other than Narcan. Don't try to make them vomit or give them something to eat or drink. Don't give over the counter drugs. So, as you can see, most of this is aimed at the airway. Keep the airway clear. This is respiratory failure. We don't want anything in that person's mouth, liquid or solid. As far as injecting the person with salt water or milk, that's kind of a street thing. And I guess for it to be in the training, someone actually would have had to have done it at some point. I can't imagine it, but and then people will think, well, they're on a downer. Let me inject them with some amphetamine or cocaine and see if that wakes them up. That will exacerbate the issue. So, what we do during an overdose, first of all, we see if that person is unconscious. We try to get them to respond. We call their name, do a sternal rub. If they do not respond, we move on to step 2. And step 2 is administering the Narcan. I'm going to show you how to do that in just a second. It is not rocket science. It is a nasal spray. It's very easy. There's just a few things that you got to keep in mind for safety. And then as soon as we administer the Narcan, we call 911. We want to get them on the phone as soon as possible. Tell them where you are. Hey, I don't know what this person took. They're not breathing. I gave them Narcan. This is where I'm at. Or I know this person took this. I gave them Narcan. They're not breathing. So what 911 is going to want you to do, like any case where someone is not breathing, is give CPR. If you're not CPR certified, they will walk you through it. This is chest compressions only. If you have an ambu bag or a mask and you want to do breaths, that's great, but it is not required by the state. They're talking about layman CPR, chest compressions here. So we've determined the person's unconscious. We want to get them on their back if possible. If for some reason you can't get the person on their back, you still want to give the Narcan, but ideally we want to lay the person on their back, peel this back, and you're going to have a dose of Narcan. It works exactly like it looks. Thumb on that trigger, 2 fingers here. We're going to insert into the nostril until our fingers are against the nose. And if you ever seen one of our kits, they do have gloves in them, so you don't have to worry about touching somebody. But this is what it should look like. And do not try to prime it or press that button or shake it before you insert it into the nostril. This button will actually stay up in there. Once you hit that button, that dose is gone. So it's ready to go as it is. So we want to insert it into the nostril, then press the button, and then start CPR if that person is not breathing. So if after 2 or 3 minutes, which is going to seem like an eternity when someone is not breathing, they do not start breathing again, there is a second dose of Narcan in these Narcan kits. So we want to take that second dose, give it to them, continue CPR. When a person does start breathing and they're laying on their back, they're most likely, after an overdose, going to vomit. So we do not want to choke that person with their own vomit. So this is called the recovery position. If they don't get up on their own, which quite often they will, they'll sit up or stand up. But if they still are laying on their back, you want to turn them on their side, hands by the head and knee out so they don't roll. So if they vomit, it can come out of their mouth and they can continue to breathe. So there's a couple of different forms. The nasal spray, obviously, is what, as ropes, we distribute. If you are not in Shelby County, I'm going to tell you how to access a ropes map so you can get your certificate for this training and a Narcan kit if you need one. But there's a few different versions of it. Some of the SSPs use the intramuscular. So if you ever come across that, all that is a shot in the outer thigh. If you ever have to use it, just needle all the way into the outer thigh and push. It disperses better in the outer thigh and it's a bigger target. So they recommend you do it there. You could technically do it in another muscle, but this is the best place to do it. So in Tennessee, anyone can get Narcan. You can get it directly from a pharmacist without a prescription. Most insurance programs will cover it or offer a copay. The range of cost is $0 to $150, depending on your insurance. $150 would be if they didn't cover any of it. There's no cost with TennCare. You can get up to 2 units per person per month. That's 4 doses per person per month with TennCare. You can use your FSA or HSA account. CVS, Walgreens, Rite Aid, all the major pharmacies have it. They know you don't need a prescription for it. Some community pharmacies, you can get it delivered by mail if you don't want to go in to a pharmacy or get it. And as you can see at the bottom, it says this program, they're talking about my program, the Rogues, prioritizes distribution for those at high risk who don't have other means of accessing it. And that's kind of a judgment thing on our part. There's a lot of people that have the means to access it, but they won't, right? And if we're their only opportunity to get it, we certainly will give it to them. And the laws around this, so we have a Tennessee Good Samaritan law that says, so you've been trained on this, you can give someone Narcan if you have any reason to believe they might be overdosing, and you give them Narcan, you have civil immunity. In other words, they cannot sue you in Tennessee for using Narcan on somebody. So you think someone might be having an overdose, even if they didn't take opioids, even if they don't survive, it doesn't matter the outcome, you cannot get sued for it. The Addiction Treatment Act is for people that are calling for medical help for an overdose. So they used to, you would call, the EMTs would come revive you, the police would come, they'd take you to jail. So after a while, they figured out this was keeping people from calling. And what that looked like was people being dropped off in front of fire stations and ERs, and in some instances, just kicked out of a car into the street or put in a dumpster. So they wanted to get this out. And I think in Nashville, they have a campaign that says, don't run, call 911, and saying you won't be arrested if you call for help with an overdose and the police show up. Now, I think there's a limit to that. They will look in a database. If it's more than once, they will take you to jail. Then we've got compassion fatigue and burnout. And this is for people who work, with people with substance use disorder. Compassion fatigue is secondary traumatization we can get from exposure over and over to other people with trauma. And, a good example, I knew an EMT who revived the same person about 12 times in 1 week, kept going back to the same house, and got to the point where he felt like it was meaningless what he was doing. And he even said, we should just let him die. Now, that's not very compassionate, is it? But things like that, if we don't take care of as we go, we end up getting burnout. And this is, as a nurse, I can tell you this is very common. It's not just substance use, it's any kind of mental health or healthcare. This can happen. And it's associated with a big workload and working with a lot of people that have some kind of physical or mental trauma. And it can lead to emotional, physical, mental exhaustion, reduced sense of personal accomplishment or meaning in work, and decreased interactions with others. So we want to find someone to talk to, understand that it's normal, exercise, eat properly, get enough sleep, take time off, journal, and develop healthy boundaries. We don't want to fall into the habit of complaining with your colleagues, work harder and longer, self-medicate, or neglect your own needs. And we do see in the healthcare field a lot of people with substance use issues that do self-medicate. So, quick quiz for your certificate. And I will read it and just read out the answers. What forms of naloxone are available? Intranasal, muscular, both, or none? And of course, the answer is both. A second dose of naloxone may be necessary before EMS arrival. That is true. You should give the naloxone and leave the patient alone. And that's false. When administering intramuscular naloxone, the best location to give the injection will be in the outer thigh. How long does naloxone last? And that'll be A, 30 to 90 minutes. And that's important, remember, because that person can go back into an overdose after that wears off. Naloxone is an addictive substance, and that is false. How do you determine when someone is overdosing? A, the patient is unresponsive even after a sonal rub. B, the patient has shallow breathing or is not breathing. C, pale, clammy skin. D, blue skin, especially around the lips and fingernails. E, extremely small pinpoint pupils. And of course, that is all of the above. Call 911 as soon as you suspect an overdose. That is true. They do want you to call 911 as soon as possible, but like it says in the training, give the naloxone first. That's the very first thing we want to do is give the naloxone and have that getting in the system. Chest compressions or CPR may be necessary. That is true. What is the Good Samaritan law? Protects you from civil liability for administering naloxone to a person believed experiencing an overdose. Any person in good faith who seeks medical attention won't be arrested, charged, or prosecuted for a drug violation. Any person who's experiencing an overdose and seeks medical attention will not be arrested. And of course, that is all of the above. And that is the end of it. Now, if you have a cell phone, I would ask that you scan this and do a quick survey. The state, loves surveys. They love their surveys. And I am number 19. There's going to be a list of the ropes across, Tennessee, and just drop down box to 19 and fill out that survey. And while I have this up there, does anyone have any questions about any of this?
I do not.
Well, fantastic. I mean, there's only 2 of you, so that makes it easy.
Well, if we don't have any questions, this was everything, right, Josh? Like we could probably end early.
Yeah, we're fine.
Awesome. Cool.
Yeah. So you are trained now, and you can get a certificate and a kit if you want to.
Cool.
But yeah, that's it. Are we good? We're done?
We are good. So I will go ahead and end the session, and then for everyone who comes back tomorrow, just go to the dashboard and start the sessions there. So thanks so much.
All right. Thank you.